Hello friends, this is Dr. Pallavi Ranjan, consultant obstetrician gynecologist and advanced laparoscopic surgeon currently working in Himachal Pradesh. So I had a patient presenting to me with complaints of 3 months of amenorrhea, previous caesarean section done 2 years back, taken MTP kit, and there was a failure of MTP kit. Hence patient underwent an ultrasound which was suggestive of a single intrauterine pregnancy at the scar site, and the thickness of overlying myometrium was 2.1 mm. The sac size was 5 weeks 6 days. So it is a type 2 scar ectopic pregnancy. So we are proceeding here with the surgeries with omental dissection and adhesive lysis, and now we are going ahead with the bladder dissection. So since she is a case of previous caesarean section, we are doing a central bladder dissection. In normally previous caesarean cases where we are not doing a conservative surgery, we go ahead with the lateral window technique. But since this is a conservative procedure, so we are going ahead with the central bladder dissection. After separating the peritoneum, we are now trying to separate the bladder fibers over the lower uterine segment and the scar site. But as you can see, normally they can be adherent. So to ease the separation of the bladder over the lower uterine segment, what we do is we insert a vaginal tube. Normally in a pregnant uterus we cannot insert a uterine manipulator, so we are going ahead with a vaginal tube. Vaginal tube basically helps with ease of plain dissection and helps in pushing the uterus cephalic, which indirectly stretches out the fibers and helps in bladder dissection. Moreover, for beginners who are not so well versed with this technique of bladder separation, it is easier and helps in tissue identification and separation of the UV fold. So here we are proceeding with end to end of bladder dissection so that we get an adequate segment over the lower uterine segment, so that even when we freshen the scar, we don't have to dissect the bladder at that time. So now you can see we have completed with the bladder dissection completely, and we are going step by step doing dissection in small bits and pieces, and identifying the tissue and separating them with the bipolar shearer cutting current. So here we have completely separated the bladder on one side, and we are going ahead and separating the bladder on the other side. Now we have identified the area of the scar ectopic. Vaginal tube insertion also helps us in identification of the cervix, end of the cervix. So here now we are injecting vasopressin in the dilution 20 units in 100 ml of normal saline, and one can easily inject 40 to 60 ml of diluted vasopressin depending upon the size of the scar ectopic. Now we are cutting open the scar site where the ectopic is located with cold scissors. We are not using shearer because it will burn the tissue, and later on the scar healing is not so good as with cold scissors. So we are using cold scissors to cut through the previous scar, serosa, myometrium to reach up to the sac. And you have to cut adequately so that the sac can be removed and no pieces remain inside the uterus. So once the uterine cavity is reached, you can remove the sac easily. This is the chorionic tissue, and now you can see the sac coming out slowly. So this is the sac, fluid filled sac, so which is coming out, and one can remove it directly. After the removal of the sac, one has to do adequate suctioning so that the remaining chorionic tissue is removed, and we have to extend the scar now so that we can refreshen the edges of this scar which we have opened. So here you can see we are doing the suctioning, and after this suctioning we will do a vaginal curating and suctioning as well under vision. So what my assistant will be doing now will be pulling the uterus downwards, inserting a suction cannula, and as you can see the suction cannula here, and suctioning has been done. So in every ectopic, we remove the excess endometrial tissue which is there due to area stellar reaction, so that it prevents further bleeding, implantation and infection. Now we are refreshing the scar edges completely, the lower edge as well as the upper edge. The reason for refreshing the scar edges is, first, to get better tissue healing, better new scar formation. Secondly, once you refreshen the edges, you prevent isthmocele formation, the lax tissue on which the scar pregnancy was located. If you don't refreshen that and remove it, the chances of isthmocele formation and recurrent scar pregnancy will become more. So once we are done with refreshing the edges, we ensure hemostasis, and we are here using a gauze piece to clear the area. And now we are going to suture both the layers. So suturing is done with vicryl number 1, round body, and one can use a barb suture as well if the patient's financial condition permits, because barb sutures are best once one has to suture, because they help in better approximation. But if not, then vicryl is also good enough. But one has to ensure that you take full thickness bites from the upper edge as well as the lower edge to prevent isthmocele formation. So here we are doing continuous suturing. So this is the first layer I am suturing, and I am taking full thickness bites from above and going down and taking full thickness bites from below. And after that I will do a second layer as well of suturing. One has to ensure proper hemostasis during this time, because then if no proper hemostasis is achieved, it might lead to post-operative bleeding, infection as well as pain. So now we are taking the second layer properly, the same as you take in cesarean section, but the depth is full thickness always. Like in myomectomy also you take full thickness bites, so here also you take full thickness bites. The need for dilator present in the uterine cavity also performs a function of enabling us to locate the cervical canal, so that we don't take internal loss in our stitches. So the dilator helps with that as well. So now we are done with our stitches, and we ensure hemostasis, adequate hemostasis is achieved. There is also a right-sided simple ovarian cyst of 5 centimeters present, so we just drain it. It is most likely a corpus luteal cyst. So the procedure is complete, hemostasis is ensured, and this is the end of the surgery. Thank you.